Hello and happy Teach Me Tuesday. Welcome back. It's 2025. In the month of December, we did not have any new videos as we kind of spoke about and reviewed our top videos of 2024. And I promised some changes here in 2025, and we are live with those changes. One of which is you'll notice that my handle on all of my social media has changed to NICUeducator.Lisa. That's who we are now. It's kind of who I always was, but I was kind of trying to play out that Houston things. And now we're just NICU Educator. And we have a new color scheme going on and a new font. I decided maybe like every January I'll just redo the colors in the font so that if you're on my Instagram page or my YouTube page, you can kind of see the difference from one year to the next. So welcome to our first Teach Me Tuesday of 2025. I decided for the month of January that we are going back to the basics and we're going to do a month of different parts of assessment. Today, we're going to kind of cover general assessment in the NICU and general assessment of a NICU baby and kind of what that means. So let's dive in. We know that neonatal assessment is a cornerstone of NICU care. We, as the bedside nurses, are the eyes and ears of the doctors, the respiratory therapists, and nurse practitioners. We're often the ones that notice the most subtle changes. With the only other people spending as much time with the baby would be the parents. Obviously, they spend the most time with the baby from minute to minute, day to day, and they should be the first person who we ever listen to when they notice a change in their baby. Anytime I've heard a parent say, hey, they don't seem quite the same today, my heartbeat starts going faster because I know that they're the one that's going to pick up on the subtle changes. As a parent myself now, I can notice when my kid's eyes get slightly glazy and I'm like, okay, there's a fever coming. It's just wild. So always trust your parents at the bedside and what their intuition is, any caregiver there. But our assessments are allowing us to identify these early signs of distress, and maybe those early interventions are going to prevent a more serious thing from happening. So when we talk about assessment types in the NICU, we're going to really dig into observation on our next slide, but really let's talk about observation, auscultation, palpation, our measurements, our neurological checks. We're not doing a bunch of percussion. I've seen that maybe intermittently once a year, maybe. I don't even want to say that often in the NICU. So even auscultation, we don't listen to 4-quadrant blood or bowel tones because we know that if you hear a bowel tone in one quadrant, it could be reverberating to all the other ones on a 500-gram baby. Now, if you have a 5-kilo baby, might be a little bit different. But saying a baby has 4-quadrant bowel tones, I'm always like, how'd you figure that out, that it was coming from that specific quadrant? So observation is what we see, what the parents see, what the caregivers see with their eyes, and when we're noticing the differences in a baby. Auscultation is when we're listening, heart sounds, lung sounds, murmurs. I am not great at murmurs. I can hear a murmur for sure. I remember the first time I did, I felt like a miracle had happened and I could hear this in my ears now. But don't beat yourself up if it's not like your strongest suit. That will come over time. And I could not tell you, oh, I listened to that murmur and I know they have a coarctation of the aorta. Lisa Houston, bedside nurse, 21 years, cannot do that. So don't feel bad. Palpation is really important, especially with capillary refill time. Our capillary refill tells us a lot about a baby's perfusion, and any change in that perfusion time is significant to them. If you have prolonged delayed capillary refill, there's probably something pretty significant going on with your baby. In fact, we may be too late. So keep a close eye on that. When we think about measurements, we're talking about their vital signs, their heart rate, their oxygen saturations, weight, length, head circumference, all of that. But really, we want to talk about what's going on with those vital signs. Blood pressure is going to be huge. It's going to tell you a lot about what's going on with the baby. None of those measurement assessments should be taken as one. Obviously, if your baby is tachycardic and in VTach, we'll take that. But a high heart rate doesn't say, oh, that baby has infection. Low oxygen doesn't say, oh, that baby needs to be intubated. We have to take the whole picture together. And that falls into blood pressure as well, because with your blood pressure, if your baby is moving well, has great capillary refill, is peeing, we're not going to just take that as its own individual thing. So I just want you to think about that when you're thinking about those measurements. So observation is the foundation of neonatal assessment. It's what we're observing. It's what the parents are observing. It is what we're documenting under observation when we're looking at their respiratory rate, when we're looking at their movement, when we're looking at their skin color. So let's talk about our skin, right? Normal is going to be that pink. It's super important for you to kind of look at the differences in skin tones and what normal skin tone should look like for those with brown skin, darker skin, lighter skin, because when I started nursing school, we did not have those resources, which is terrible. And we've come a lot further. So those, I will post some of those on my Instagram page where you can see resources of different ethnicity, skin color, and kind of what is normal and what is cyanotic. It's really great to look at. Thinking about jaundice and hyperbilirubinemia, as we all know, is one of my favorite words. Are they mottled? Is the baby? I sometimes look mottled. I remember when my 11, almost 12-year-old was born. I remember she is so pale, just like me and my husband. She has more even of his coloring. I was like, she's mottled. She's mottled. Do we need to do something about this? Does she have a congenital heart disease? And they're like, no, she's just pale, like you and your husband. So always take those things into consideration. With their movements, we really want to look at hypotonia. That can be a sign of sepsis or a neurological impairment. When I don't feel good, I don't want to move around. I just think about that all the time. Like when I am tired, have a cold, anything, I'm laying around. And then hypertonia can be signs of neurological injury or withdrawal. You will see that sometimes in HIE babies in the NICU or your withdrawal. And then your behavioral state is your movement, your oxygen consumption. Is the baby waking up? If your baby is a 32-weeker, they're probably going to start waking up before feeds, moving around. 37-weeker definitely should be doing that. If they're hard to arouse, that's something to keep in mind. And again, I have it here. Parents are key observers. My baby's breathing seems different today. My baby's not as active today. My baby usually sleeps between cares and isn't sleeping. Typically, if I give the baby the pacifier, they kind of settle in. Listen to those. That should not give you goosebumps, but do that little heightened awareness. So in infant activity, we are thinking about, do they have the energy reserve to be able to kind of do their, ADLs, their activities of daily life. If you've heard me say this before, I remember the first time I heard about a baby getting occupational therapy, and I was like, babies don't have like a job to do. And then I'm like, oh yeah, their job is to eat, sleep, and poop. So an occupational therapist is going to help them do those things. So keeping those things in mind, those babies with high activity that can have good energy reserves and are coming out and doing that versus those with low energy. Thinking about what do their movements look like? Are they jerky? Are they smooth? And then do they overreact and do they rest well between activities? All that's kind of cueing us in to what's going on inside. When we're doing that quick assessment of their respiratory patterns, we want to see breathing rates of 40 to 60. Again, your baby is going to establish a baseline. That's what I love about EHRs, electronic health records, is you can go back and see what is going on with the baby's heart rate, with their respiratory rate, what their normals are. Kind of, you can graph their vitals in certain EHRs. I highly recommend that. It'll kind of give you their midlines. Their periodic breathing is a normal finding for them. We've talked about this so many times. You'll see that, right? That periodic breathing. As long as those briefs or pauses are short, 3 to 5 seconds, pretty normal. We're going to see some abdominal breathing. It's what is your baby's baseline? You don't want to see seesaw breathing. You don't want to see retractions to the spine. You don't want to see subclavicular retractions. Grunting. Remember, grunting is auto-peeping. The baby is applying CPAP to themselves because they cannot exchange their gases and they need to keep their alveoli open. No one can do that for a long period of time. Grunting is auto-peeping. Your baby needs peep. And then, of course, apnea is a pause in breathing greater than 20 seconds. Apnea prematurity is a diagnosis of prematurity. We expect premature babies to do this. So how do we help them with that, and how do we help them get better? And then our heart rate. Heart rates are very variable. As you may recall, the smaller you are, the higher your heart rate. Hummingbird's heart rate is significantly higher than an elephant's heart rate. That is because of your cardiac output. With each push, there's not that much blood coming out when you're a hummingbird or a 500-gram baby versus a 5-kilogram baby. An elephant, each time it comes out, their hearts are so big, their cardiac output is bigger. So think smaller babies, higher heart rates. It's going to be very normal for it to be 140, 150, 160, even sometimes 170. So again, knowing what your baseline is, thinking about that baby's baseline and what is it doing during activities. It's probably going to slow down when they're sleeping and they're comfortable and they're resting, and go up if they're crying, agitated, or moving. We also know that bradycardia is part of this apnea of prematurity, kind of can be a normal finding. Heart rates less than 80 are also very normal in term babies. If you have a baby in your NICU with HIE or is months old or has a cardiac anomaly, you may see these lower heart rates, and that's when you're going to want to get your monitor alarms changed. What is your baby's response to disturbance? So this is another part of assessment that you really want to see. With your physiologic responses, you should see some change in heart rate when you wake the baby up. Maybe some change in elevation, brief normal response. A respiratory rate has a brief normal elevated response. You might see a quick oxygen desaturation. As long as none of that is sustained, the baby's doing great. A behavioral response could be crying. Intubated babies can cry. Just because you can't hear it doesn't mean they're not crying. So watch that grimacing around their face, that discomfort, or they completely shut down and they're just not moving for you. So our job as the nurse is to think about, is any of this frequent? Frequent desaturations or prolonged bradycardia is a red flag for instability. Prolonged distress, even with minimal handling, what's that telling us about the baby? Do they have something going on that we aren't quite capturing? Have we missed something going on with them? It's not just what are they doing, but for how long are they doing it? So that is teaching us to look at our stress cues. So our physical signs that a baby is stressed is going to be that pale, mottled, that change in color. Their respiratory effort is going to change. They may be grunting, flaring, or retracting. The behavioral signs are huge. Hiccups are a sign of stress because our diaphragm is moving abnormally. Yawning, the furrowed brow, which I have pointed here with this beautiful white arrow that I could not get to do what I wanted, and I just had to accept it. Finger or toe splay. This baby is having both finger and toe splay, but the toe splay is so obvious. I wanted to make sure we pointed that out. That's telling us, hey, I'm stressed. Can we take a break? Can we dim the lights? Can we reduce the noise? Maybe you're Lisa Houston and you talk to me while you're doing cares. Maybe I don't want to be talked to right now. Maybe your mom's singing. Maybe the dad has a phone on watching a show. It might be time to quiet some of that down. Offer some containment. Two-person cares is the number one way to prevent stress cues, along with whole skin to skin. So how often should we be assessing? Routinely, probably every 2 to 4 hours. There was a big push to Q6-hour cares for a long period of time. I'm not a proponent of Q6-hour cares. I've talked about this a lot on Instagram. I've probably talked about it on here on YouTube before. The reason I think that Q6-hour cares is too much is that babies move a lot in utero. They're peeing frequently. No baby's just going 6 hours and not really getting any care. So we have great diapers now. They kind of have that line on them when they're wet. If the baby wakes up during your care, I really believe assessments and care should be cue-based. When the baby wakes up, is stirring, we should get in, change their diaper, do their temperature. I don't think we should wake a baby up just to do those things. If they're comfortably sleeping, then they're probably okay. But if they start showing us some of those stress cues or prolonged desaturations, it's time to consider, is it an assessment time? And that's really important because if we pass over those times and then they do get into sleep and then we hit that 6-hour mark and then we have to wake them up, that's not great either. And then we're going to have our acuity-driven adjustments. So when should we be going in and assessing? If we're having any worsening or changing vital signs, a change in a urine output, a change in a state, that means we need to go back in. So maybe it's only been 2 hours, but we've noticed this baby's had a lot of Brady's in the last 2 hours that isn't the same for them, or they really can't get back to sleep. Then we need to go in and do an additional assessment. That's the baby's way of telling us what's going on. Remember, they don't talk. Some of us, that's why we love NICU nursing, one of the many reasons. And we need to get in there and see they are talking to us in their way by changing their state or changing their vitals. So we need to do an additional assessment, and then you can restart your 2 to 4 hour clock from there. And of course, documentation. If you didn't document it, it didn't happen. Yes, there are ways that we can document some things in other locations, but it is so important that you document the assessments you do. So if you go back in between and suction, if you go back in and listen because you notice that the heart rate on the monitor isn't quite matching the baby's activity, document that. We need to accurately document what we're seeing. So exact vitals, use descriptor words. We need to do it in a timely manner. Documenting in the moment is the gold standard. Going in and filing in your EHR, pulling up the vitals right when you walk in the room, instead of coming back later. What if something happens in the meantime to that baby or one of your other babies or in your personal life and you have to leave? You need to document in the moment. Trend tracking. You can do that within EHRs or you can do it yourself, kind of see what's going on with this baby, what is their response like, have we had any serial changes, how can I be on top of this? And then sharing that during shift report. I think shift report can be, I mean, I could probably do a whole hour on shift report. Maybe we should. We'll add that to the list. But we really need to use our shift report as a way to talk about what has been so important in your shift. What have you spent time doing? Because that's going to kind of dictate, hey, I didn't have to spend any time suctioning yesterday. Oh shoot, I did like suction during my entire night shift. Maybe the baby's having a respiratory issue. Maybe they have pneumonia. So sharing those observations during handoff and then making sure that the parents' observations are also documented. You can say provider called to the bedside to help appease mom's concern, to help talk with parents about their concerns. Mother or baby noticed change in infant's behavior, assessed, no changes at this time, whatever it might be, but making sure that we are acknowledging that they are the single most important caregiver in their baby's life. So for our parents, we want to tell them why we're assessing, what we're looking for. Anytime I'm going in there and, doing a belly assessment and saying, I'm like, this is what I'm looking for. This is why I'm looking for it. I want to make sure that your baby's belly isn't getting bigger, that they still have good bowel tones. If you notice, that it looks bigger or discolored, I want you to tell me. If you notice your baby's skin color looks different, I want you to tell me. Empowering them to share their observations and to ask questions. But if we don't tell them what we're looking for, they can't be empowered to share because they don't know what's different. I love to talk out loud if the baby can tolerate it when I'm doing an assessment when the parents are there. That way they know exactly what I'm looking for. Not that they're not going to tell me, but hey, I'm coming in and doing my assessment every 3 hours. If you notice something in between, if you notice the baby is doing X, Y, or Z, make sure you let me know. Call me into the room. Call another nurse into the room. Let somebody know so that we can assess this further. And then obviously empowering them to do things like temperature checks. Obviously, we're going to do auscultation, but wherever they can have some control over what's going on is going to be so helpful to you. So neonatal assessments are critical for monitoring a baby's health. On average, we perform these assessments every 2 to 4 hours, kind of depending on what's going on. We're observing stress cues. We combine all of that with our clinical expertise, our collaboration with our parents, and we can provide comprehensive care that is tailored to this baby. That we've said, hey, these are the trends. This is what the family's saying. This is what I'm noticing. We can provide these babies with the best possible care. Thank you for joining me for this Teach Me Tuesday here in 2025. So happy you're along with me. We're going to stick with our back to basics for January and a little bit into February because we're going to talk about a lot about hearts in February in case you were wondering. But have a great Tuesday and I will see you next week.